Thank you, sir.
Actually, in tomorrow also I've got 2 online presentations with the Orthopedic Trauma Association of USA and American Academy of USA. So they are both scheduled for tomorrow. Today, luckily, we don't have anything else.
Yes, sir. This year, the Egyptian Orthopedic Association will arrange the second conference, sir. It will be between 20 and 23 of November in Cairo.
I'm quite likely coming.
Yes, sir. It's an honor.
I have seen only Cairo, and I have to see the Alexandria and all those cities around. I have still to see. So I hope
you have to see Luxor and Aswan, sir.
Yes, Aswan. I have to go here. So
yeah.
One of your boy was with me for last 1 month. He has promoted a lot of Egypt with me. So I hope I should be there. So how is the weather in Egypt right now?
Excuse me, sir?
What's the weather like at your place these days?
The weather, it's hot now. It's about 37 degree.
Okay.
It's very hot.
Okay. I mean, for us also 37 is hot, but still we have a chance to go to 40 or sometimes. So
yeah. we also, sometimes it goes up to 40 sometimes.
Okay. So we are matching for that level, that means.
Yeah. In July and August, it's very hot.
Okay. And you have a humidity also coming up in July, August?
Yes, but not like the Southeast Asia. I was in Malaysia, in Thailand, in Bali, in Indonesia. It's very humid, but not so humid like in Southeast Asia.
Okay. Because humidity itself creates a lot of pressure. I mean, that makes life very difficult in that scenario.
Yeah. Professor Aymen is joining.
So that's great. Good evening.
Good evening, Professor Aymen.
Hello, my friends. Good evening.
Hello, sir.
Thank you very much for the kind invitation. Dr. El-ashhab, thank you. It is my pleasure
so much, Professor Aymen, for being with
you
us.
And our Indian colleagues and friends. It's my pleasure. I'm really pleased to be with you, and I can see that it is a very long course that's going over at least 10 or 12 weeks. So quite huge amount of effort from different and from the organizers. I'm really glad to be with you.
Thank you so much, Professor Aymen. It's an honor to be with us, sir. Thank you so much for accepting my invitation. Thank you so much.
Thank you.
Professor Aymen, would you like to check your presentation, sir?
Yeah, well, I would love to. I'll try to share my screen.
Yes, please.
And see how it goes. How's that?
Yes, sir. Yes, sir. It's good.
Okay.
We have 3 minutes to start, sir. Professor Aymen, we have with us Professor Ramesh Sen from India. Professor Ramesh, I think he was the former president of the Indian Orthopedic Association, sir. And we have my dear friend, Dr. Srinivas Kambhampati from India. He is the moderator and the instructor for this course from the Indian side.
Well, it is my pleasure to meet both of you. And yes, it's a virtual meeting, but I'm in the not far distant future.
Yeah. We hope we'll meet soon in Cairo for the CCOT meeting. That will give a very good opportunity for getting physically with each other. That's too good.
We hope to see you there, sir.
Yeah, hope so to be there.
So how is the meeting is going to start? There are 2 talks, I think, or 3 talks. Not sure how is it going to run.
It's going to run after 2 minutes. We'll start. Professor Ramesh will start his presentation, and Dr. Srinivas will introduce Professor Ramesh, and then we'll make the discussion with him and with the attendees. And then you will be the next speaker, sir. I will introduce you and you will make your presentation. And we have about 5 to 10 minutes discussion, sir.
Sure.
Okay.
Sure.
We are ready to start, sir.
Right.
Yeah, well,
it's a great honor for me to
recording in progress.
To announce the start of the today presentation. After the last week, it was a vacation, and now we will continue our Egyptian Indian online orthopedic course. And now we have very special presenters. Professor Ramesh Sen from India. Professor Ramesh was the former president of the Indian Orthopedic Association, and from Egypt, my dear friend, Dr. Professor Aymen Ebed, the former head of the orthopedic department, Menoufia University, and he's specialized in joint arthroplasty and arthroscopy. And I think now he's the president of the EGA, the Egyptian Arthroscopy Association in Egypt. I would like to thank my dear friend, Dr. Srinivas Kambhampati from India, for being sponsoring this course from the Indian side. Thank you so much, my friend. We will start with the presentation of Professor Ramesh, and Dr. Srinivas will introduce Dr. Ramesh. Dr. Srinivas, please.
Thank you very much, sir. As always, thank you for the opportunity. It's a pleasure to moderate this session. And can you see my screen?
Yes, sir.
yes.
I'm pleased to introduce Professor Ramesh Kumar Sen. He is very well known in India. He was the previous president of the Indian Orthopaedic Association. He works as a senior director and head of the department at Institute of Orthopedic Surgery in Max Hospital, Mohali in Punjab, in India. And he has a vast orthopedic teaching experience of 34 years, of which 20 years he was at one of the premier institutes in India, postgraduate institute in Chandigarh. He is a visiting professor in universities in Germany, USA, and Canada. He had presented in the grand rounds in Harvard and University of Virginia in USA. And he's also been postgraduate examiner in Malaysia, Mauritius, Nepal, and for MS, DNB, and FNB degrees in India. He has authored more than 200 research papers and 15 chapters. He has 6 patents, 5 published and 1 applied for, and more than 35 international and national orations, and more than 10 fellowship awards. And he's a founder, president, association of pelviacetabular surgeons, and past president, North Zone Orthopedic Association in India, and past president of Indian Orthopedic Association just the last year. He's now the ex-president. He's a member of AO International Pelvic Expert Group, and he has been faculty and delivered lectures in more than 100 international and more than 500 national and regional meetings. He's a regular faculty at AO and other pelviacetabular courses, especially all over India as well as internationally. He's course director in more than 110 pelvic courses and has an experience of conducting more than 25 live surgical and more than 50 bone model and cadaveric workshops. He has extensive experience on avascular necrosis as well. That's the topic for today. And I'm very honored to introduce him and very grateful for him to have accepted this invite to give a lecture here. Over to you, Professor Sen. Thank you very much, sir.
Thank you, Dr. El-ashhab. Thank you, Srinivas. And I'm really happy to be here to get over to this, to the meeting. And I do hope that we will be able to interact more in the future also. So right now, as Dr. Srinivas told, I have been working on avascular necrosis for last 20 years. When I had the first interaction, I'll let you know in the due course of time, I developed that interest and has been working in this area. A part of the research work which I have done in AVN includes the part of research was sponsored by Asian Association of Dynamic Osteosynthesis from Hong Kong, and part of my research has been sponsored by AIOD from the France. These were all the projects which I did in 2004 to 2008. All these projects were sponsored by these two agencies. Now, as we understand, avascular necrosis from various etiological factors culminates into the ischemia, necrosis, repair, and a structural integrity loss leading to collapse. We understand that the patient is likely to be symptomatic, but it doesn't mean that every patient is symptomatic from the first stage. Many patients represent late. They have been painless till the time the disease has progressed reasonably fast. Then groin pain can be anterior, anteromedial of the thigh, can get exacerbations, and subsequently the range of movement can be affected, can give us a sectoral sign also. There was a time when we were diagnosing it with SPECT diagnosis, which did not have a much sensitivity. And then we moved over to MRI images where T1 images gave us a single band area of low signal intensity and T2 images giving the second high signal intensity. And this MRI made us clear regarding the amount of area involved and the site of the area of involvement. Definitely we have been differentiating it from something called transient osteoporosis, which is a self-limiting, which specifically affects a specific age group, specific gender. And it is sometimes confused, but that can be differentiated now. If you want further to know, MRI contrast dye, which is retained for a longer period, does tell us about the relatively less perfusion in the AVN. Then we did publish one of the earliest studies of using 18F fluoride PET-CT in these cases, which had a sensitivity equivalent to an MRI sensitivity. The patients who are not likely to have MRI for any reason, we have found this could be the next best investigations. And then we have evaluated this pre and post core decompression also, whether our studies are likely to give it that certainty in the amount, in the kind of a management also that we have been able to do. In the day of today, there is no single criteria for diagnosis. We depend upon few things, few X-ray findings, few bone scans, MRI, and histology. But a specific thing which we notice, we have not put any clinical status or a clinical symptomatology in the list of diagnostic criteria, because some patients may not present till very late while the inside the disease might have spread. So for the definitive diagnosis, any two of these five can be called as this thing. So that remains. Then Fickett staging is a kind of a standard staging, which is dividing the progression of the disease, whether it is a preclinical status, it is a pre-radiological status, pre-collapse status, collapse, and osteoarthritis. Then we did study the epidemiological profile of these patients in our population. We found it out that 54% had a bilateral in the study which we did about in cases with us, and non-traumatic was bilateral in 61% of the cases. We had a steroid as one of the most common cause in our series. Then it was idiopathic, and close by was the alcohol in our cases. When we looked at the distribution at the time of their first symptomatology, what we found it out was that they were mostly presenting at a stage which is too late in some of the cases, 48% stage 3 and 33% stage 2, and likewise very early presentation of these cases. And we had a unilateral and bilateral distribution also in these cases. Then steroid dose, we did find it out from this study that it has got a strong effect in the occurrence of AVN. More than 16.6 milligram per day prednisolone had 3.4 times higher incidence as compared to the lesser dose, and that was there in the kidney transplant patient also. There is another report from India from one of our institutes where they found it out that elevated level of homocysteine has been consistently concomitantly found with the reduced level of vitamin B6 and B12 in these patients, and this is published in the Nature as such. Then, now what is the concept today? It is very important that every AVN is not the same AVN. We must define the quantitative involvement, which can be in the size of the area, or it could be the volume which is affected. Defining a volume is technically demanding, but size could be easily made it out. Now, if we look at the lesion size, it has been seen that if the hips have a larger lesion volume, then it's very difficult to have a control. Smaller lesions tend to reduce in size. There is a slow, and MRI is also slow and a time-dependent kind of a process. I'm going back to my interest in AVN. It was a 3-month-old neglected dislocation hip where open reduction was done way back in 1997. Because it was a 3 months, so I was expecting this has to go for AVN, and actually it did. So here is the X-ray in the start. At that time, MRI was not so freely available at the place when I had this patient. So we got it done from somewhere, and the MRI did show a kind of a avascularity. Then, because we were not very sure what has to be reasonably done, we kept on monitoring the patients till he was asymptomatic. It is 98, and down there you can see 2001, some changes were there, but MRI. The otherwise clinically he was asymptomatic. It was 2005 when he first became symptomatic, and you see the radiological picture was reasonably bad, and now he has started feeling difficulty in sitting on the ground and sweating. And it was in 2007 when he felt that he needs a replacement to get back to normalcy. So from 1997 till 2007, in spite of a diagnosis of AVN, he kept on going for the initial 7-8 years. He was asymptomatic also, even after the clear diagnosis and after a clear this thing. So at that stage, there was an issue. Would I have diagnosed it at the early stages also? So we did a study. We looked at the cytological analysis in cases of a dislocated hips when we were doing a open reduction, that we will aspirate it out from the superior part of the femur head by using a needle. And what we found it out, eventually we correlated with the AVN at a 6 months follow-up, and we found out that if that aspirate of the superior part with the 18 gauge needle and a 50 cc syringe maintained for 1 minute, if this aspirate is less than 1 cc, it is likely to be avascular. And this is what we have eventually published also, that early diagnosis of ischemia during the open reduction can be made at that stage by looking at the amount of aspirate. Working on avascular necrosis then for last further find it out that 20 MRI years is able to predict the outcome, and as per this literature, if there is a bone marrow edema, if there is a subchondral fracture, if there is a effusion, these are the cases likely to lead us to that collapse. But what was very important was the quantification of the involved area. So this was done in mid-coronal and mid-sagittal MRI pictures, and combining both these angles, so-called Karbol angle. So if the lesion on combination of these two angles is still less than 190, it is a small. If it is 190 to 240, it is medium sized, and anything more than 250, the combined, then it is large. Now, why this is important? Because larger the lesion, worse is the prognosis, and smaller the lesion, better was the prognosis. Then there is another paper which came out again from the north part of the India. They did a volumetric study of the involvement, and they correlated with subsequent outcome also when no intervention was done. And they found it out that all lesions where the volume involvement was more than 25%, they eventually ended up in a collapse, vis-a-vis lesions with more than or less than 25. So there was a difference. If it is less than 25, they were better off. More than 25 were all getting to collapse. Then we found it out which classification system is most useful, and we found it out Japanese classification was most reliable and effective for the early stages than other classifications proposed till that time. And this classification simply describes the amount of involvement and area of involvement, how much it is medial, how much it is trying to reach to the lateral part, whether it goes out of the acetabular margin or it stays within. So first is A, where it is still within. The second is 2, when it is just reaching to the dome. Third, when it is reaching to the joint level, it is C1, and next is C2. So C1 and C2 are likely to have the poor outcome. Now, the question was how to manage. The very simple and a conventional advice was restrict weight bearing. But this literature says whether you restrict or do not restrict, it does not osteoporosis, which is a self-limited histological studies. Then various therapies were tried: hyperbaric oxygenation, XRR, shockwave therapy, pulsed electromagnetic field stimulation. So all these were tried. They had a good paper and they had a good evidence that they are useful, but somehow these were never actually used in a product which specifically affects a specific age group. This is a paper again of HPO therapy which has been in few of these studies. It is sometimes confused, but provide a reasonable amount of improvement, but again not being in a wide practice, that kind of a thing. People did try anticoagulants also with the perception that we might have a coagulation abnormality as the basic factor. This may help, and this is affecting the practice of many times affecting these anticoagulants. People did try iloprost, and as in addition to the general anticoagulants also. And a very important perception came from 2002 by few of the experimental studies when it was found it out that bisphosphonates can be useful in reducing the chances of femoral head collapse. Then 2005, we had 2 clinical studies, one of them from India, and both these studies emphasized, and they gave a very interesting demonstration. This paper, though it is written late, but it has seen that the osteoblasts are likely to take 3 months for the building up of a new bone, while for osteoclast it is 3 weeks time. So meaning by when both these cells starts getting into the area, osteoblasts will take time, osteoclasts won't take time, and they immediately will resorb whatever resolved around, and then there remains a mechanical weakness in which the head can collapse. If we are giving bisphosphonates, we are slowing down the osteoclast to match with the speed of the osteoblast so that collapse may not happen. With this concept going on further, there is a systemic review which found that this could be useful at the early stage, but there is a rider with small necrotic size. Now that means we are talking about A, or we may be talking about B, but we are not talking about C. So A and B could be okay, that's as per. But same time another paper came in which they took out those papers from one author, and then they concluded they still do not have that strong evidence that it should be given. This is in 2014. And by that time, we were realizing that core decompression is one of the standard technology, but in technique, we make a bigger hole. So, and bigger hole can give a chance of a fracture. So there came another perception that why not to do with multiple small diameter drillings so that you can break the barrier which has formed around the lesion at multiple places and still provide a decompression at other places with much less risk of fracture as compared to the conventional one. And in between, there came a specific systems with us in which we could inflate the inside cutter. We could curate out all the necrotic bone. We used to scoop it out. And instead of that, you can put a calcium paste, you can put this bone marrow concentrate, or you could put bone grafts also in this kind of a system. So then there came a paper whether which is better. It is restricted weight bearing versus core decompression. And it was found core decompression is an effective strategy as compared to weight bearing. And then MRI was also done in this thing. And this also said it as, yes, core decompression is an optimum thing in the care. As far as the outcome of core decompression, how effective it is, that it shows that it can approximately 40% of the patients will go on replacement on an average of 26 months. So meaning by 60% of the patients are likely to get the benefit of it. We also appreciate that post-traumatic AVN happens at 3 levels, type 1, type 2, type 3, depending upon size and location of the lesion. And when we look at the fracture neck femur, we understand this happens more with the displaced fracture. In men, it is more in women, and then it is more in that less than 60 years of age group. Now, take this an example of a fractured neck femur where the fixation was done, but they had to collapse, and then the disability started. Incidentally, 2015, there is a paper that there are reports of AVN in non-traumatic situation. There is no paper which says about traumatic AVN. It has written specifically that core decompression, orthopedic surgeon colleague who got a dislocation, I reduced the dislocation, but his MRI showed that he is developing avascular necrosis. So in addition to this thing, I asked him, can I inject your blood bone marrow from bone marrow into the lesion with the expectation which somebody has published? He says, yes, he can do. So I started. Now 17 years later, there is a inadequacy, this thing, but he doesn't have a AVN at that stage. So enhanced with that, we started this study in the association of AIOD Hong Kong and this thing. So we picked up cases of steroid and alcohol and idiopathic cases also. And we used to take the blood out in a very sterile environment in the OT, used to process in the lab, where we were using phycolayering method, centrifugation, separation of the plasma layer, and then subsequently we were washing it with a buffer after a lot of cleaning, then we were keeping it for the use. And this way we used to get a concentrate. We used to get the culture for all type of infections, this thing also, but this is the tube. And then we were doing with the long needle after using a bone wax to seal it to enter this area and to provide these cells. Now I'll show some example. This is a case of a Cushing syndrome, bilateral AVN, bilateral core decompression done, but there is already a collapse on one side, other side still a collapse to occur. This is one of our own patients where we had kind of a Hodgkin lymphoma where steroid was given, and you can see the involvement over there. We classified it as a C1 centrifuged and prepared by these people to culture, and then they used to give us a culture cells also. And what I found it out here, you can see the case up and now the newborn formation starts very fast. This is another case where we did it, and within 6 months we had got a reasonable amount of a newborn formation as per imaging. So we did publish, and this publication, it was a journal authority. It is one of I think it has got more than 270 citations for that kind of this thing. So now as we had put up the paper, the review started happening about this BMAC into this area. So you have a review in 2014, 14, 16, 17, 17 and 19. So there is a reasonable list of multiple reviews. They're all reviews which were done for this kind of a installation. Rods were produced from the company and we started having it. Now this is a safe alternative, it is supposed to be, and it keeps the body also relatively unspoiled. So we started using this stem cell introducer, or you can say a 3D printed trabecular metal rod, which we used to pass through the hole. It used to settle. You can see down there in X-ray also a kind of a placement where it is able to support the newborn over there. And eventually, other thing which has been a gold standard is the vascularized fibula. This is a situation, this is a case where we had got these situations and we did vascularized fibula. It was somewhere around 2002 where we have done it out. And then you see this patient after 11 years has herpes reformed. So in the day of today, if we have to say what is a gold standard, vascularized fibular grafting is a gold standard. Keeping aside, it is technically a demanding kind of a procedure. Then people did say that they can use vascularized fibula or non-vascularized fibula also in this kind of a situation. They can draw the bone from the iliac crest as a vascularized graft also. And this also we did in some of the cases. And there is a literature supporting that this is not bad in kind of this thing. Now the other muscles graft were also used, just like Moderator's muscle graft in these situations. And in this kind of a muscle pedicle graft, they found reasonable good outcomes in these cases. Then I'm thankful to Dr. Sawaguchi, who got me these X-rays from Suzioka. The X-ray showing the lesion in the bone, subsequently showing the plan of rotational osteotomy, and then subsequently the execution of rotational osteotomy. but somehow these things have not been propagated to that degree. Then there is another rotation osteotomy called trochanteric rotation osteotomy also, which actually does the same thing in a little different way. And what is to be best? Some things are uniform to both the types. The kind of a age, the kind of a BMI, the kind of a stage, they are all important in the outcome. So it was subsequently found that transtrochanteric curved varus osteotomy is much better than the other osteotomies we may be practicing. So if we look at these articles, yes, all these articles says there could be, but there is still a conversion rate of 30.1% in spite of taking all care. Now, people did use a cementation of the femur head also by elevating it, because we all understand that we are putting a cement in many places. So here, why it should not be done? So it was done, and there is a report that it was reasonably a good study, but that's all we know about it. We all understand that we are putting autologous osteochondral graft into the defects also. And if you are putting graft, they may be preserved also. So this is a kind of a memory-shaped femur head for the AVN in which it has been applied, and the patients can walk around, give a load over the affected site, and that can work it out. In these situations, then came another option, because in COVID, we saw that they had a lower threshold level of steroid and earlier onset of presentation. And so we maintained a kind of a management, just like here, where they had symptoms, they are grading, we did their assessment by curval angle, and then we found it out, this kind of a curval angle, but you see the amount of involvement of this area. This is significant. So we did a core decompression, we got this thing, and then subsequently things improved to a great extent in this kind of a situation. So this is another paper where they are talking about where do we stand today. So again, looking at the literature, what the topics which we had seen for pure core decompression to multiple drilling to cell-based therapy to use of tantalum rod or the osteotomies can be there. So they developed a guideline for the diagnosis part first. When to diagnose, and whenever you become sure it is done, you can go further for the management. But till the management is to be thought of before that, we must have the workup done for these patients. So what we see in the day of today is that if we have got pure core depression, that we will be doing in the stage 1. If we have a stage 2, we will do core decompression, add graft, add marrow stem cells into that area. Stage 3, we are only trying to decompress and add some kind of a femoral graft or a metal rod. And then the stage 4, when we are doing arthroplasty, at that stage, obviously, you can give that option to the person to postpone depending upon the symptomatology. So many patients may feel difficulty, many patients may be able to accept it. So this is what we understand in the day of today. Thank you.
Thank you so much, Professor Ramesh, for this very interesting presentation. Dr. Srinivas, please.
Thank you very much, sir. That was an excellent presentation. It was with very extensive literature, research, and sharing your experience and insights on this important topic. If I may ask, start off with the questions. I think there is one
period of 3 to 6 weeks. Once they feel stable enough and once they feel capable enough, they can go out and get into. But we do advise them to avoid any jump, jerks, and to be careful in their activities in their career.
Do you allow weight bearing, full weight bearing after this decompression?
Yes, because this is a decompression with a very small stem pin, not more than 4 or 5 mm, and multiple points, but entry point is 1 only. And when entry point is kept 1, we have very less chance of getting this collapse. And incidentally, let me share, out of maybe 600 cases where we have decompression, I got one case where we had fracture, and that happened on both the sides. So that it was entry going. So we got it tested. It came out to be osteogenesis imperfecta tarda variety. Otherwise, we never had any case getting a fracture in this kind of a situation.
I think there's one more question from Dr. Mohamed. Many patients have other medical problems and must take steroid for a long time. How to prevent effect of steroid in progression of AVN hip?
Yes, it is anticipated. Then people have found it out there that these lipid reducing drugs, atorvas, can be helpful. We have no recent studies, but in the past published in clinical orthopedics research, are there a few studies which said that if you have to give it, if you give simultaneously these atorvas kind of a things, these lipid lowering diseases drugs, they may be beneficial in this kind of a situation when you have to give steroids. But keep the dose of steroid less if it is possible. Again, that is a kind of a reduction we can have.
Professor El-ashhab, sir.
Yes, please, sir. Professor Ramesh, thank you for very much for this interesting presentation. I have a question for you, sir. In case of bilateral AVN, do you prefer to do them at the same time, or you prefer to do them separately so I can allow the patient to have one leg to stand on it?
As I told you, I do not completely restrict them. And because time is a very big factor, so you cannot keep the patient waiting for first 6 weeks and subsequent 6 weeks. So we do a core decompression with that level where the hole made is very small inside. We do allow them immediately ability to go to the washroom and go to their essential activities. So to save his time and to start well in time on the other side also, I do it. But there is a very special instruction that I do primarily for the edematous stage, when the edema is there in the first go, and second I do when I have to break the barrier. My aim in the stage is to break the barrier of those lines which has formed between the dead bone and the live bone. So you have to do multiple drilling at that point within the femur head so that you are able to break it up. Now that does not alter the outside anatomy, and all our weight bearing progression does not really increase the chance of collapse or chance of breakage out. So I'm comfortable with our protocol of having a 6-week limited walking or limited ambulation. I do reasonably often the same time bilateral also.
Prof. Aymen, I think have a question. Prof. Aymen?
Yes, well, it is a very interesting presentation. I really enjoyed the review that you presented, Professor Sen. I have a question, if I may, because we're suggesting using fibular grafts even when the patient has passed the collapse stage. What do you think of the long recovery period following these vascularized fibular graft, and whether this would help someone to get back to work as quickly as possible?
Yes.
The other point is the vascularized fibular graft. In fact, it is, but might have a very long recovery.
How difficult is it to do a total hip after rotational osteotomy? And what are the results of such a DHR? And is there a role for a short stem arthroplasty in these cases?
Yes, there are two questions. As far as the first is after the rotational osteotomy, I don't have my personal, but as for the literature, it is very clear that if you have a rotational osteotomy, the outcome is likely to be less than the standard post-AVN THR. As far as the second question is concerned, that do we use a smaller stem? Yes, the problem with the smaller stem is that we still do not have a long-term outcome of smaller stems. So various designs of smaller stems have come. Considering these patients are at a very younger age, and if we have put a one standard small stem, we do have a chance of still a so-called normal stem and then subsequently a third revision. So smaller stems are encouraged, but the number of cases done are still not that significant enough to say that it is good in the day of today. But most of the companies within their standards have reduced their length also. So many times that can work in this regard, not the classically so-called very small stems.
And you said some of the patients can be asymptomatic until advanced stages. So how do you suspect AVN? Any tips on differentiating back-related and AVN-related pain?
Yes. So if they are painful, that's very important. If they are painful, as a classical symptomatology, the pain coming into the groin is AVN pain vis-a-vis a pain going backward to the gluteal area. And if we are reasonably careful in asking the patient for this evaluation, along with the clinical evaluation, we do perceive that we can make a reasonably appropriate diagnosis. But I am not saying that most of the time we'll be able to make it. There will be cases when it remains confusion. And as we have realized, many cases come getting an MRI of the spine with subsequent small picture showing down there of the hip, and then getting a MRI for the hip joints also. It is a common thing which we tend to miss it out. But I feel it's more care, and especially many of them will remain asymptomatic. By the time now they get manifested, they may be now manifesting as a degeneration happening in that asymptomatic joint. So now this symptomatology may be of degenerative character rather than the classical AVN character. So that is the difference which we tend to see.
Professor Aymen, sir.
Yeah, please. It is a very interesting discussion, and I'm learning from Professor Sen many things while I'm listening to his vast experience in treatment of AVN. And as you said, there are many patients who present late. The head had already collapsed and arthritic changes had started. While there are others in early stages of AVN, and they cannot tolerate, they are coming with severe pain and they are seeking anything to relieve their pain. They cannot tolerate the pain. Do you have any kind of shedding some light of differentiating these two types of patient? Is it something that is related to pain threshold on the patient himself, or is something that is related to the pathology?
Yes. What we have seen it out, then the patient is symptomatic significantly, bone marrow edema and a kind of a small effusion definitely is seen in that hip joint. Actually, when we treat them also, it is disappearance of bone marrow edema in next 6 weeks or maybe 12 weeks, but immediately the pain starts disappearing. That is what we have seen in our study also way back in 2005 and 6 also, that by 6 weeks to 12 weeks, the bone marrow edema syndrome disappears after core decompression. And likewise, the symptomatology, the scoring system, if we do score them properly, that also changes. So a patient coming acutely with the pain is likely to have a reasonable amount of a bone marrow edema, and his symptoms will restrict him from the general ambulation. Vis-a-vis those patients who do not know about it and keep on talking, who are representing late as a degenerative phenomena, which does not subside. Now, there is no question of having edema. There is a degeneration already. So we need to differentiate that acute presentation where there is a reasonable amount of a painful hip coming up with the classically pain going down, restricting the movements, which definitely is the early stage. The only differential diagnosis, as I told, is the transient osteoporosis. And many times this is very confusing, and many times they are changed from the AVN side, but a careful look into that. Incidentally, we have a radiologist who is working with me for last 15 years on AVN only, and we have been able to do a few of the projects with it. So we have been able to have those clarity in understanding what level we are with the AVN and what level we should say, no, it's not AVN. It is a kind of a rather another feature which I found, a patient coming at 50 years or 60 years is not likely to have AVN. They may have more kind of a stress fracture occurring in the poor quality bone. But that doesn't mean this could never happen. I saw some cases of AVN happening at that stage also. But age is a very important factor. A patient coming with the hip pain around 30 years of age or 32 years, and these days after the COVID, now our suspicions have become reasonably high in suspecting it to be AVN.
So is there a role for
papers, rather 7 or 8 papers I have quoted also, a series also, that it can be used for. The problem with all these studies is that once done, twice done, thrice done, either due to non-availability at most places or due to lack of understanding of that therapy, they have never been progressed and got into a clinical usage. They have been experimental to work on. They have the limited studies also as compared to, let's say, bisphosphonates. This is widely used as compared to bone marrow. This concentrate also widely used. So some things which were easily available were widely used. And once widely used, we know their pluses and minuses. And today we can vehemently say, yes, this is good, this is not good. But what about these therapies? Yes, they found some good, but this could never progress beyond that level of work. So I think that could be one of the factors, so that we don't have a firmness in their usage in the wide clinical sense.
Okay. Thank you, sir. I think there's any more questions, sir?
I think no more other questions, Professor Srinivas.
Thank you.
Thank you so much.
Thanks
Thank you so much, Professor Ramesh Sen. Thank you so much for
Thank you, Professor.
presentation, sir.
Thank you.
Thank you, sir. Thank you. It's my privilege. I am really obliged.
Thank you so much, sir. Thank you so much. It was an honor for us, sir. Now we'll move to the next speaker, Professor Aymen Ebed from Egypt. Professor Aymen is a professor of arthroplasty, and he is the president of the Egyptian Arthroplasty and Arthroscopy Association and the former head of Orthopedic Department, Menoufia University. Professor Aymen, please.
Thank you very much, my friend, for giving me the opportunity to listen to very structured and well delivered talk from Professor Sen. This was a very nice presentation that I really enjoyed, and I'm quite happy to be in this webinar with you. I'm the past president, by the way. I'm not the current president. So having listened to Professor Sen and his wide experience and vast review, I'm going to give a brief presentation about my rationale of selecting patients for different methods of treatment. There will be a very quick introduction about the pathology, and perhaps the diagnosis and the etiology have already been well covered. But I'll move quickly afterwards to the options of treatment, whether it is joint preserving or joint arthroplasty, and my rationale of thrombosis and retrograde arterial occlusion. And this would result in avascular necrosis or osteonecrosis of the femoral head. I like always to correlate between what happens pathologically and what we see on the imaging studies and the radiological studies that is being performed. Because when necrosis happens, new vascularization invades the necrotic segment, and bone resorption around the necrotic segment starts to weaken the bone around the necrotic fragment, and therefore, or the subsequently, subchondral fracture and happens, and new bone formation starts to form to engulf the necrotic segment. So what we see on the X-ray is a combination between a necrotic segment that has retained its original sclerotic appearance in comparison to an area that has been invaded with new blood supply and new vascularization and hyperemia that results in osteoporosis. So essentially, at the beginning, the necrotic fragment keeps its original bone density. But afterwards, when collapse happens and when the microfracture happens, condensation of the trabecular bone increases again the sclerosis of the necrotic fragment, and that's what we see on X-rays and CT scans that's performed. So you have to remember that the necrotic fragment doesn't get more sclerotic, it just retains its original bone density, while the surroundings, in reality, being invaded with new blood supply and the hyperemia happens in it, leads to osteoporosis or reduced bone density of the surrounding bone. When the we like always orthopedic surgeons think biomechanically, and we keep thinking of why collapse happens and what happens when the dead bone get exposed to stresses. And we realize that the modulus of elasticity of dead bone is 70% less than the viable bone. The ultimate break strength of the dead bone is 50% less than the viable cancellous bone. And hence, fatigue fracture and collapse results in bone collapse from underneath the articular cartilage. You see in this specimen that I've taken during a hip arthroplasty, the collapsed bone, the neovascularization, and the weak bone that is underneath the articular cartilage, as being said by Professor Sen just a few minutes ago. It's not an articular cartilage, but the pathology is in the underlying or the subcondylar bone underneath the articular cartilage, while the articular cartilage itself was healthy up until the collapse happens. We know very well that there is a long list of etiological factors that have been blamed for causing the increased intravascular coagulability and causing the avascular necrosis. And many occasions we say it is idiopathic. Apparently we didn't reach to the reason, or we couldn't reach to the reason in these cases when we say it's idiopathic. But what we can see, really an increased surge of number of cases of osteonecrosis that appeared over the last few years is directly related to the COVID-19, because COVID-19 in itself can cause avascular necrosis, and this there are many patients who presented with osteonecrosis of the femoral head that happened as the result of the COVID-19 infection, despite the fact that they weren't being given corticosteroids. So in itself, it causes osteonecrosis, and this may be the reason for the increased number of cases of avascular necrosis that appeared over the last years. MRI scan is considered the gold standard in treatment. It makes a good and accurate diagnosis, discover this early, and we have to look at the bright signals in the T2 images and the dark areas in T1 images. X-ray usually are normal in the early stages until the sclerosis and the collapse subcondylar fractures happen. And there are different stages for the avascular necrosis. But you see on the far right-hand side of the screen that all what you can see is some sclerosis and cystic changes within the femoral head. And we see clearly the crescent sign in the second X-ray in the middle. And then the head flattens and secondary arthritis becomes obvious and supersedes all the findings when there is osteoarthritic changes that affected the acetabular side afterwards. So, as I was saying earlier, this gentleman, actually he's a young man, all what he had was a COVID-19 and no steroid treatment. And despite the fact that he had no steroid treatment, he had developed bilateral avascular necrosis of the femoral head. So in itself, it can cause the avascular necrosis. I think Professor Sen has covered very well the different classification system. And the FICAT system, in reality, despite being one of the most famous classification among orthopedic surgeons, but there are many doubts in regard to the reliability and inter-observer agreement on the different classifications of FICAT classification. And you have to remember that the FICAT classification was based on core biopsy, while the curval angle grading, I think the volume of the involvement of the head, as being said earlier, is very important aspect of the classification and for future prognosis of treatment of different modalities of treatment of the avascular necrosis. The Steinberg classification, well known, and I think it is one of the standard classification system that we are all referring to in our current practice for the treatment of avascular necrosis. Now we'll move on to the treatment options, and as being said, extracorporeal shockwave therapy, electromagnetic pulse therapy, and hyperbaric oxygen, they all help or try to improve regeneration, proliferation, and new angiogenesis. But in reality, despite the fact that there are few publications that appeared that support the success and the use of electromagnetic pulse therapy, hyperbaric oxygen, and the shockwave. But I can't see in the literature that there is widespread agreement on the value of these modalities. And as I said, perhaps it might be available for some patients to have hyperbaric oxygen, but I'm not sure really if we can recommend it to all of our patients, because I can't see that after these two publications that appeared in the literature, there is widespread acceptance of the idea or being recommended on the guidelines of treatment. There are two important issues in regard to the treatment, I think. I think we all agree now among ourselves that if there is one single procedure that has stood the test of time, it's core decompression. The realignment osteotomies, and I heard Professor Sen talking about the Shizuoka osteotomy, for example, the rotational osteotomy. The problem with the rotational osteotomies and the realignment osteotomies is that, in fact, the success that was achieved with these osteotomies in Japanese patients hasn't been replicated anywhere else around the world. To the degree or to the extent that some surgeons thought that there may be a difference in the blood supply of the femoral head in Japanese patients in comparison to the rest of the Asian and other population around the world. So I fully appreciate the fact that rotational osteotomies and realignment osteotomies having a very attractive mechanical theory of offloading the avascular fragment, getting it out of contact with the anterior superior part of the acetabulum and getting it out of load. But I see that the recovery period following rotational osteotomies and intertrochanteric osteotomies is very long. And I think it makes future hip arthroplasty more difficult for the hip surgeon than if an osteotomy wasn't performed in the first place. And because of the long recovery period and because of the inconsistent results that can be seen in different parts of the world with these techniques, I think it went out of favor in many institutes and being replaced by joint arthroplasty than maintaining the intertrochanteric osteotomies. And forgive me for telling this story because I did my MS thesis when I started my training in Egypt, and this was in 1994. And we were very encouraged by the results of intertrochanteric osteotomies in these times. And I'm sure all of you, especially the older generations of orthopedic surgeons, know very well the Bombelli biomechanical studies and how he encouraged many surgeons to perform the valgus extension osteotomy. And we know very well that our early phases of training, our professors were very enthusiastic about performing intertrochanteric osteotomies. But I can see as the time goes by, and in the last 35 years of my life as an orthopedic surgeon, the intertrochanteric osteotomies and the rotational osteotomies have gone out of favor in many institutes because of the long recovery period and the difficulty in performing hip arthroplasty afterwards. Now, the core decompression. I think this technique has stood really the test of time, and I was quite glad to hear Professor Sen when he was talking about changing in the technique of the core decompression. So instead of the big, large hole that we used to perform in the center of the head, we have now moved to the multiple small drills that breaks the island and gets into the avascular part from different sides. It has very big reducing venous congestion and pain because it reduces the intraosseous pressure and it stimulates neovascularization and the open channels for new bone formation. It is usually recommended for patients with grade 1 and 2 disease pre-collapse, because if mechanical failure has already happened, I don't think core decompression would be highly advised or encouraged because of the success. And you see, I was telling about the multiple drilling and core decompression, and instead of using a very big hole in the middle of the neck of the femur, multiple drill holes with small drill diameters might help these patients in achieving better results than the large big hole in the middle. And we see that it can achieve good results in cases of bilateral AVN, like this gentleman who came pre-collapse. Now, what is the outcome of core decompression? The meta-analysis of around 1,200 patients showed 84% success for the FECAT stage 1. And this success dropped to only 65% in FECAT stage 2. What was interesting to say is that the bone marrow concentrate improved the results of core decompression in general. And I think it is one of the techniques, and I heard Professor Sen speaking about his own lab, who makes the centrifugation of the bone marrow aspirate, and perhaps this may be a point of discussion when we finish this presentation. That really, I see the bone marrow concentrate as a very good tool to be added to the core decompression, especially that we can see after 30 years of follow-up of a prospective randomized study of 125 patients that it has improved the survival of these hips. And we see that the rate of total hip arthroplasty following a core decompression was reduced by 74%. The rate of when bone marrow concentrate, there was added to the core decompression, it has reduced the rate of conversion to a total hip replacement by a significant number. It was a highly significant result, improvement of the results of core decompression. But I heard actually Professor Henniger, while making his presentation and his presenting his results, and I asked him, and he says, yes, I do it for stage 1 and perhaps the stage 2A. But he was doubtful about the outcome in patients in stage B, and definitely he doesn't recommend it for stage 3 type of patients. So we're talking about patients in stage 1 and 2. Perhaps stage 2A are better than stage 2B. How to perform the procedure? Well, I think, as I said, I was glad to see Professor Sen saying that he has got his own lab, but we know that Zimmer Biomed has got their perfused percutaneous decompression system, which is really nice that in many occasions when we perform the core decompression, and I used in the past, and I'm going back 10, 15 years, I used to perform the core decompression and try to push calcium phosphate and calcium sulfate granules into the hole that I've made into the femoral neck and head. But obviously, delivering whatever you would like to deliver, whether it is going to be a bone graft, whether it is going to be bone marrow concentrate that you would like to deliver, would need you to have that trocar and sheath system to deliver the bone concentrate into the femoral head and neck. And this system actually has helped very much in delivering these. The other point is it is a closed circuit all the time. So from the time that you penetrate the iliac crest and you withdraw the bone marrow from the iliac crest to the time that you inject into the femoral head, it is a closed circuit. It is sterile all the time. And that's what encouraged me really to use this system for the last few years since being introduced to our market, because I could see that it is secure, safe, and you can deliver the bone marrow concentrate into the femoral head in a consistent way. Now, this is an example for the patient who might be helped with the core decompression and bone marrow concentrate. And you see the bone marrow edema, how much marrow edema. This is how this is the procedure under CR, and you see the changes that happen to the MRI scan in 3 months, having performed the core decompression and the bone marrow concentrate infusion or injection into the femoral head. You see the changes that happens, and you believe in the system, and you believe in the technique and the selected type of patients. This is a pre to post MRI scan for this gentleman. Now, again, this lady who had AVN on the left side. I performed the left side, and then she appeared with post-COVID with AVN on the right side, for which I did core decompression again. And you see the difference between the left head that was performed before having COVID, and the right side that was received core decompression and bone marrow concentrate, but it was post-COVID. Yes, well, there is no collapse so far, but you can see that there is a difference in the result overall. Similarly, when you get these patients bilateral AVN, on the left side is still neurological changes that can be seen. On the right side, you can see a crescent line in the subcondylar bone in this young chap who's only 24. So I was enthusiastic to perform bilateral core decompression, and you see him 6 months after. The left side has fully recovered. The right side, where there were more advanced disease, but small fragment, so still not fully collapsed head, but you still see the crescent sign, and there is an obvious, clear difference between cases that's being performed before collapse or pre-collapse in comparison to those who had more advanced stage of disease with crescent sign apparent on the MR and X-ray preoperatively. Similar case, but you see, it's not without complication, and sometimes surgeon got carried out and performed things that perhaps weren't threatened. So, as I was saying earlier, we moved out from using these big core drills into the femoral neck, but apparently the surgeon was enthusiastic to help this 24 years old male by performing a very extensive, actually, I would say, core decompression using 2 large big drills into the femoral head, but it didn't last. It resulted in a fracture neck of femur when he started with bearing 2 months after. So sometimes it can carry complication, and surgeons should be aware with the possibility of complication if you get enthusiastic and carried out performing things that weren't written or weren't recommended. Now, you see young girls with avascular necrosis, polycollapsed head, and they cannot tolerate it, and they like to live their life. And when I see a patient with complete collapse of almost 60-70% of the head, like what's seen in this right side, I cannot offer them anything but joint replacement, because I'm sure that with the joint replacement, they will live almost a normal life. Everything has got its risks and its complications. And my role with these patients is to give them the information that they need. And I think the decision should be the patient's decision rather than the surgeon's decision of when to perform. We see X-rays for patients with far more advanced arthritic changes than what we see in this, but they cannot. They can tolerate, they can live with it, and they can wait for a few years. While we see young ladies and men who are really very young, this lady was only 22, I think, but they cannot tolerate it. And when you speak to them to the different modalities, they say, well, I would like to live a pain-free lifestyle now and get back to my activity. And I'm quite prepared to have a revision 15, 20 years time if I need to. But I would like to have something that gets me back to my level of activity. And I know this is debatable very much, because we see patients, and in fact, this is a point of debate that may be raised afterwards at the end of the presentation, because we see young patients, 14, 15 years old, with this systemic lupus. They are steroid dependent, but they are in wheelchair. And I can't see an alternative but to perform joint arthroplasty in them. And this is. I'm not encouraging to perform hip arthroplasty in very young patients like these, but at the end, these are patients who deserve to be looked at. And if it is one of my relatives or someone who is a family to me, what decision would I make? Would I do a hip arthroplasty or anything else if I have the choice? This is a question to be raised in the air for everyone to think about. Now, sometimes you get patients with bilateral AVN that is advanced. The patient cannot tolerate the pain, and he's healthy young chap and would like to get back to his activity as early as possible. And then many of these patients, you can perform bilateral total hip under the same anesthetic. So they can get up and walking from day one. Obviously, a shorter recovery period, but with a higher risk, obviously, than the standard techniques. So what is the outcome of total hip arthroplasty for AVN? When compared to osteoarthritis, similar rate of aseptic loosening to total hip for arthritis, with 2% at 10 years. Long-term survival is comparative to total hip arthroplasty for osteoarthritis. There is a higher rate of dislocation, and this is understandable. Patients who are steroid dependent and alcoholics perhaps have a higher rate of complications as well, regarded to PGI and all complications in comparison to the other groups of patients. So, what should I remind you with before the end of the presentation? Perhaps before structural changes, no crescent sign, no collapse, good prognosis, joint preservation, particularly core decompression and bone marrow concentrate injection. While after structural changes, after collapse, there is usually poor prognosis with joint preservation. And the timing for joint arthroplasty should be the patient's choice. It shouldn't be the surgeon to choose when to perform the surgical intervention, but it is for the patient to choose for himself when to have a joint arthroplasty. At the end, vascular necrosis is a challenging disease with controversial treatment modalities. Core decompression has stood the test of time, and I think it is quite suitable for all patients pre-collapse. Bone marrow concentrate, platelet-rich plasma. I'm not sure about platelet-rich plasma so much, but I'm sure and confident of the current evidence with the bone marrow concentrate that it enhances the potential for healing and long-term survival. Total head provides successful, consistent, pain-free mobilization in advanced stage of the disease. And at the end, I would like to thank you very much for giving me this opportunity to be with you this evening. Thank you.
Thank you so much, Professor Aymen Ebed, for this very interesting talk. Thank you so much, sir.
Thank you.
If we have any questions to Prof. Aymen, and I start with a question from me, please.
Please, yes.
When you are doing a core decompression by multiple drill holes, how much drill holes do you perform, sir?
I usually try to limit the penetration of the lateral cortex to 2 holes, or maximum 3 holes, usually above the lesser trochanter. And usually I use these 2 holes or 3 holes by redirecting the wires again to reach to the different edges of the necrotic segment. So I try to avoid creating very big stress rider on the lateral cortex of the femur, and reach to the necrotic segment from different directions. Especially, I like to look from AP and lateral views as well to make sure that I will reach to the necrotic segment of different directions as much as possible.
Yes, the size of the drill that you use it.
I use the 4.5 drill.
Yeah. And for the system, the Zimmer system for injecting the bone marrow concentrate, you are introducing it by hammering. You are not afraid that it may break or bend or something like that?
This is a very good point, because I realized very quickly, and I think, in fact, the actual trocar and sheath system is manufactured in Egypt now, so it is not the original set. What I'm using is something that's manufactured in a workshop next to me. But what I do is I start by opening the lateral cortex with a drill bit, so I avoid hammering the outer cortex, and I insert a wire even to find my way to the exact area where I would like to go to the necrotic segment. Having inserted a wire, and made sure that the direction is the correct direction, I remove the wire, and then I insert the trocar and sheath when the cortex has already been opened by the drill bit.
Yes, sir. Professor Ramesh, please, sir.
Yeah. So there are a lot of questions to talk about and discuss about, but I'll be a little brief in the sense. First thing is, do you think at stage 1, when there is only edema, do we have a rationale of using BMAC at that stage?
Well, I think if there is massive marrow edema, it would help. It would help in regeneration, neovascularization in general. And yes, it is a stage 1, and the core decompression in itself would achieve successful results in general. But the bone marrow concentrate perhaps is quite suitable for the early stage 2 than stage 1. But generally speaking, if I have the chance to use the bone marrow concentrate whenever I do core decompression, I will do so, because it helps, and there is enough proof and evidence that it will help the potential of healing and the new angiogenesis of the femoral head.
Actually, I don't know. I did that study also in my cases, that these cases I differentiate into when there is edema only, when we did not give BMAC in all of them, considering that maybe we are over enthusiastic about BMAC. So I restricted giving to about 40 cases of bone marrow edema. At the edematous stage of the stage 1, we did not give it. And 2A, you rightly said it, but 2A, whenever there is a barrier, we break that barrier, we clear it out. Definitely, we feel there has to be neovascularization. But when there is an edema, I don't know, I'm just voicing my this thing. If you decompress, the decompression brings down the edema, the vascularity returns back. And that is what we found. The results were not different. So whether I add BMAC at stage 1 or not? I have not found a difference.
I see your point quite clearly, but yes, perhaps we are not far from each other in what we are saying, because the actual decompression itself and taking the congestion from within the femoral neck and head might be quite adequate if it's in stage 1. But I be quite honest, we hardly see patients in stage 1. We usually see them when they have moved to stage 2A or 2B. And these are the majority of the patients who receive actual core decompression. Very few patients present to us in stage 1.
My second question. Then
Please.
When you are giving this bone marrow edema, are we counseling the patient? Because I tend to counsel my patients that my core decompression will give you about 60% recovery chances. I don't promise more than that. And I further say that if I add BMAC, I'm not saying culture cells, I'm just saying the BMAC, my chances of recovery for you will be increased by about 10% more. 50 to 60% is core decompression, and 10 to 15% is the addition of these cells over there. That is my perception. So how do you counsel your patients, and how much you believe the role of core decompression and giving the BMAC along with?
You see, I don't think, again, we are too far from each other in this, because I usually try to be very conservative on how much hope would I give to patients with avascular necrosis in general. However, having said that, I'm not giving different figures or percentages more than what you give. Usually, if I said that in the best case scenario, it's 70% success with the addition of bone marrow concentrate. So whenever I see a patient in 2B, I become more pessimistic and I give him a more pessimistic mixtures. And sometimes I do these bilateral cases. So if it is 2A in one side and 2B into the other side, I usually say to him, it is usually 40-50% on the 2B side, and it's usually 60-70% on the 2A side. And when he asks me, what do you mean by 60-70%? I say to him, well, the literature tells us that 7 out of 10 who, from those patients who receive this procedure, will remain without a joint arthroplasty for 10 years postoperatively. But it doesn't mean that you are guaranteed to stay pain-free or not to need arthroplasty in the future. But we are just trying to delay the need for the arthroplasty rather than anything. And obviously, you see, patients are different. And as I was telling earlier, you see a young lady, 20 years old, with collapse of the femoral head, and she cannot tolerate, she cannot sleep. She cannot tolerate the pain. And you see someone else who is really in stage 5 and 6 of the disease, and they are going to their farm.
There is
I was raising the point of when to tell the patient to have a joint arthroplasty for AVN. And it's only last week I was performing a hip arthroplasty for a patient whom I saw 20 years before. And he said to me, I came to you 20 years before, and you told me that you can live with this disease for as long as you like. It's only when you tell me that my pain is severe and I cannot tolerate it, you will perform a hip arthroplasty for me, and now is the time. You see what I mean? So I don't rush patients to have arthroplasty. I only leave the decision for the patient. I can only give him the options, and it is for the patient to determine. And I can remember one of my great teachers, Mike Grableski, when I worked at Wrightington Hospital. He used to say that The primary arthroplasty timing is the decision of the patient, but the revision should be the decision of the surgeon.
That's fantastic. Now, I'm sorry, I have many questions.
Please.
The question is that when you have a C2 type of a lesion, meaning by overall the superior dome is involved, it has gone beyond the level of the acetabulum, there is a reasonable amount of a certainty with a wide, big carbon angle that this hip will not survive. Patient is symptomatic. Are you still giving him a hope that the core decompression will succeed? I mean, are you using the quantification during your prognosis or not?
No. Well, it is if it is a major part of the head that is involved, that's reaching to the edge of the. I don't try to push patients to get core decompression. I don't do it actually, or I recommend for the patient to try to use crutches for some time to do physiotherapy. If they pass already the stage of collapse and it is a flattened head, so I don't do any core decompression for these patients.
Okay. Then, let me stop at this stage. Otherwise, I think I don't give any chance to anybody. We have many things to discuss. I hope we find another forum sometime later to have more questions.
Yeah, well, I'm sure we'll see you in the CECOT in Cairo next November.
Dr. Srinivas, please.
Sir, I have a couple of questions.
Please.
One for you and Professor Sen as well. How do you manage your asymptomatic AVN patients? You have found out on X-rays there are findings, and you do an MRI scan, there is AVN, but the patient is asymptomatic. How do you manage? And the second question is about bisphosphonates. Which patients do you give bisphosphonates? Do you give for all? And postoperatively, when do you start the bisphosphonates?
Thank you for the question. And I see very few patients, usually elderly females, who might present with minimal symptoms. They are not totally asymptomatic, but with minimal symptoms. And they are accommodating the pathology. They are not enthusiastic to have anything done for it. And in these patients, perhaps these are the good indication for the bisphosphonate. And these are the patients whom I'm not in rush for anything, to do anything. They have minimal symptoms, they have minimal activities. Apparently, there isn't much in terms of bone marrow edema or heavy effusion, because I think I agree totally with the fact that patients with effusion and marrow edema are these two important factors that aggravate the symptoms for patients with AVN. But you see sometimes some elderly males and females who have minimal symptoms. No symptoms, I can't see it, but I see minimal symptoms. And this perhaps for the fact that they have very limited activities. And these elderly persons, I think they are good candidates for the bisphosphonate.
And if I have to answer that, usually the situation is the other side of the involved hip, which may be asymptomatic at that stage. So what I do again, I am very much fond of using Japanese classification. You quantify the lesion, you estimate the chances. If it is type A, type B, and no edema, I just tell them that you have a lesion, but most likely you are not likely to become symptomatic ever, because things will just go and come past. But if it is C1 or C2, I tell them if there is no edema, right now you are little okay, but anytime if you start developing pain, be careful immediately to get into the system and find out the management before it is too late. If there is a significant involvement, I see, but they are not symptomatic. Again, I'm looking at that scenario, what you said, it asymptomatic. Because if there is edema, they usually are symptomatic. We don't have any patient who is edematous and asymptomatic. So these are these lesions where there is no edema. There may be involvement, but there is no edema. So in those cases, if there is edema, obviously they are symptomatic, so they come into. But if they have no edema right now, they are asymptomatic, it is just a warning to them that right now you have no reason, but any factor, any injury, any excessive stress by any of your activities can aggravate it. And if it is like that, expect the outcome could be bad. So be proactive in that kind of a situations and get back to the medical care. That's the way I take care of these things. Prophylactic core decompression, I have not done. And as far as it was very well said, alendronate, there is no problem in giving that. It is the least harmful among the available options. So I give almost every patient alendronate undoubtedly, whether they help or not. But because of it being so less problematic, I give to all the patients where I do core decompression, I do core decompression for a 2 years period. We give it.
When do you start, sir, post-operatively?
We can start immediately also. I have no restriction in starting. At the day I diagnose it, I say if it has to be effective, why not from today? So I started.
Yes, sir. We have many questions from our dear attendees. I think the first two questions, Professor Ramesh have already answered them. First question, when to start mobilization post-core decompression? I think you have answered it, sir. And the second question, what treatment given post-operative and for how long? I think you have answered it, sir. Another question, can we use regular key wires when drill over with cannulated drill pad if the resources are not available? Professor Aymen?
I wouldn't encourage you to do so because they are weak key wires. We know the state of manufacturing key wires in our countries. How is it like? So I wouldn't recommend it. So you would better restrict to or keep yourself restricted to standard instruments to avoid complications.
Yes, sir. Another question from Dr. Mohamed Osman. Vascularized fibular graft would help at any stage of AVN.
I personally don't have wide experience. I've just read the literature, and as I said some time ago, I did a thesis on the intertrochanteric osteotomies. So when you read the literature for the microsurgeons, they give you the impression that it is the magic solution for all cases of AVN. While when you read the literature for cases that were converted to total hip arthroplasty, you know that there is quite few of these who have failed. So, but I think I totally agree with the concept that was presented by Professor Sen that it is helping the biology if you have the skills. It's helping the biology by delivering new blood into the area. But it's not being used, I think, or I don't think he has recommended it for mechanical support of collapsed cases. So the concept has to be taken as free vascularized graft are good in delivering new blood supply into the area. It's not necessarily being the fibular graft because it could be an iliac crest or a different area. Whether all orthopedic institutes have the facility of a microsurgeon to perform this or not, I'm not sure. And the problem is you are talking about a procedure that can take 6-7 hours to be performed, perhaps more. And at the end, does it make a huge difference from core decompression and bone marrow concentrate or not? I'm not sure. Perhaps we will never know the truth, whether there is a difference or not. I don't know what Professor Sen may think about this.
As far my perception is concerned, it is stage 2B. In stage 2A, I am quite comfortable this breaking down the barriers, curating and putting the fresh graft along with BMAC mixed or using culture. But when it goes like little more maturity of the barriers and it is pre-fracture stage, at this stage, I am looking for a vascularity to a reasonable assured way. And that is what we have done. We use vascularized grafted, that is mechanical stability is still there. So we are biologically augmenting in a very strong way. So that is my indication for a vascularized fibula. But if you start getting the crescent, now this vascular solution may not work mechanically. And frankly telling you, that is my stage for non-vascularized fibula as a mechanical strut to put a support for that breaking bone. And now in this scenario, I use a 3D printed metal rods. We have just got a patent for that also as a substitute for fibula, non-vascularized fibula. But in this patent, we have got this metal rod along with the central canal through which I can inject stem cells and which can go out like a flower to all the area around. After injecting, it gives me mechanical stability and it also gives me a solution to put my BMAC into that area. So this is just at the time of the collapse. Once collapsed, we did try some cases to rebuild also, but we have failed. So I personally failed, once failed. Now there is two situations now. As they fail, during that failing process, when it is happening, patients are significantly painful. Once that collapse happens, they become symptom-free. And this symptom-free period can last a bit longer also. It could be 2 years, it could be 4 years. They will have a limp, but they may not have a pain. So I tell at that stage that now it is likely to collapse or it has collapsed. You will have few years of limping gait, but pain-free gait. The time when you start becoming painful, depending upon your perception of your abilities, your look or your clinical features, if you feel you are feeling bad, arthroplasty will be the solution. And if you feel you can, painlessly, you can manage. Many of the rural patients tend to manage like this. They do not want any cosmetic thing. You can continue like that. And the day when you start feeling again, now it is symptomatic enough, now come for arthroplasty as an option. So I look it at a stage 2B before the fracture is likely, not afterwards.
Yes, sir. Dr. Amr Sharif has two questions. The first one, I think you have already answered it. He has another question. When should we notice a change in the femoral head after core decompression? I mean, when should I worry about the result during the follow-up period?
I think in the successful cases, usually there is a good observation. Patients are partially weight-bearing or touch weight-bearing early on, but they get rid of the pain that was there pre-operatively, and this is a very good indication for the success of decongesting the femoral neck and head. I think you start to be worried if there is a progression of the disease, or if you see that there is increasing pain rather than reduction in patient's pain, and this is usually being seen between 6 to 12 weeks postoperatively.
Yes, sir. We have another question from Dr. Mohamed Osman. He is asking about Elizarov head distraction. Would it be helpful at least would increase the blood supply to the area of the head? He's asking about the arthrodiastasis. What's your opinion, sir, in this age?
Be quite honest, I'm not sure really if it is well studied. I know that there is hip destruction procedures being performed in pediatric patients for cases of Perthes disease or as a salvage rather than as a primary treatment for cases of Perthes disease. But I'm not sure if this has been tried in adults. And my worry is that pen tract infection may dominate the situation and makes joint arthroplasty more difficult and of a higher risk in the future. So I'm not sure. I don't have experience, obviously, with external fixation around the hip joint, but I hear from my pediatric surgeon colleagues that they are using the destruction procedure for the patients who have failed the treatment of Perthes disease to improve the congruity and to reduce pain, to improve the stiffness. I'm not sure if this has a role to play in adults.
My perception is that in hip, this is a long process. And the philosophy is okay that we take the weight off, but we can't take the weight off for approximately 2 years. If we can use any device to be offloading for 2 years, it may work as a basis, but it is not practically possible. And because I do have an experience in ankle joint, sometime when the talus starts developing AVN, we can give a brace which is offloading the talus as such. And we had seen that the longer use can show that change. But in a hip, I think having the arthrodesis things kept for 2 years is not possible. And less than that, probably the disease is so slow, it may not really be beneficial. So I don't think we should be thinking currently in that line that arthrodesis could be an option.
Yes. We have a question from Dr. Sultan Mohamed. When do you think, Professor, of have your experience about making a bone tunnel and full fillet with cortical bone from the proximal trochanter area to promote the head vascularization?
I think we had been using the technique of making it kind of a rounded bore into it, reversing the trochanteric side to inside and then pushing it back so that the fresh area of the trochanteric area goes inside it and the disease area comes outside. That has been a procedure reasonably tried, but it has not affected the result much. I mean, you cannot say that that will stand the test of time. A lot will depend upon the lesion over there.
So once you inject the PMAC, how do you stop it from coming out from the tunnel?
This we have various ways. Initially, we used to put this needle with this thing, but now we use a cannulated drill. You put a cannulated drill, make it tightened enough over that area, we may be able to see it. But we have seen that if you have put a drill bit, which is big in size, it is reasonably put. But the second thing is very important. We tilt the patient for the gravity to allow us to stay. We put this 3 cc in 20 minutes. We spend 20 minutes in drop-wise irrigation to that area rather than pushing it here. I remember the Hernig has written way back, you keep on pushing. I remember his first publication when it was in CORR. He says, you say 25 cc when he was not really concentrating, he was putting the marrow as such. And I did that in the same case because he has written it out. You can keep on pushing, let it come out, but you keep on pushing. But no, when you have a concentrate of 3 cc, then go value every drop because we did a quantitative cytology also. So every drop means a lot of cells over there. So drop wise, spend time, and frankly in a routine, we spend 20 minutes for that 3 cc to get into that area. That is the way we do it.
The last question from our dear professor, Professor Adel Anwar from Minya University. Welcome, Professor Adel. What's the difference between bone marrow concentrate from either anterior or posterior iliac crest?
I routinely use posterior iliac crest because I feel the amount of cellular characteristics are much better. Second, we get a reasonable amount in a very short period of time because you have to get within that time limit. If it's long, you get a blood rather than marrow. So in the posterior side, as you keep on rotating and aspirating, the chances of having adequate 120 cc are much better in the posterior side as compared to the anterior side. That's my, I don't know, but Dr. Aymen view, what is doing here.
Thank you so much, sir.
Yeah, well, it is understandable because it is wider area of. But I think you still get good amounts of bone marrow concentrate from the iliac crest in general. The posterior side, as you said, it is white cancellous bone, so it's going to be rich in cells.
Thank you, sir. I think we have no more questions. Now we come to the end. I think this is one of the best days in this course, which will last for about 6 months, I think. Many thanks to Professor Ramesh Sen from India and Professor Aymen Ebed from Egypt for their very fruitful presentations. Many thanks to my friend Dr. Srinivas, to OrthoTV for live streaming these presentations to all over the world, and to EVA company for sponsoring this course. This is one of the best days I have ever seen in either in this course or along my online career about 3 years ago. Thank you so much for these very fruitful presentations, and hoping to see you in Sikot, Professor Ramesh in Egypt and Professor Srinivas. Thank you so much, sir, and see you next Friday, inshallah. Thank you so much, sir. Have a nice night.
Thank you very much.
Thank you so much.
Good night.
Good night. Thank you so much, sir.
Good night.
Thank you, sir.